Stage and grade are different things. Stage refers to how far the cancer has spread. Grade refers to how angry the cancer looks. Stage 1 cancer is a small cancer. It means it's under 2 centimeters and the nodes are negative. If it's between 2 and 5 centimeters, or if the nodes are positive, it becomes a stage 2. If it's bigger than 5 centimeters, or if there are complications associated with it, some of the changes in the skin we talked about, or ulceration, that's stage 3 disease. Stage 4 disease is when it has spread to other parts of the body. And to be honest with you, in general, for stage 1, 2, 3, you are treating the person with the intention of trying to cure them. And for stage 4 disease, you're treating them with the intention of trying to keep the cancer under control. And thankfully, in the case of breast cancer, much more so than in other cancers, even when we sadly have to have the conversation with somebody that your cancer has spread and there is not really a prospect for cure with the cancer, generally we can tell people there's a very good prospect that you will live for many, many years with the cancer under control. I always use the analogy of other chronic diseases. I say to people, look, you've asked me if it's curable, and it's not. But rheumatoid arthritis isn't curable, diabetes isn't curable, blood pressure isn't curable. These are conditions that you live with and we treat to keep them at bay, to keep your health the best we can for as long as we can. And the truth is, in the case of spread breast cancer, overtly spread to other parts of the body, for most patients, that's where we are. Those patients typically live for many years with the cancer under control. Sadly, not being eradicated, not being cured, but under control. The issue with respect to the lymph glands historically has been that it's a sort of a barometer for the cancer's ability to spread. In general, a cancer which at the time of diagnosis is confined to the breast and where the lymph glands are found at surgery and at various other tests to be negative, that person has the best outcome. Still not 100%. Some of those patients will sadly still come back some months or years later with spread of the cancer, telling us that just because the glands were negative doesn't mean the cancer hadn't spread. That's a decreasingly small minority. If the cancer has spread to the glands, the chance that there has been spread to other parts of the body which you cannot as yet detect is higher. It's not uniform. I was actually giving a lecture today in Dublin City University, and I was showing a very old slide of the first mastectomy series done by the famous Baltimore surgeon Halsted, who started doing radical mastectomies in the 1890s, and fully 20% of the patients in his series who had the breast removed, who had the lymph glands removed, and who had cancer in the lymph glands still did not relapse. They were cured. So sometimes the cancer has gone as far as the lymph glands and no further. Sometimes it has gone further. And that's why, in general, if the lymph glands are involved, for many years that's been fairly uncontroversial. That is a group of patients who should get some kind of drug treatment as well to try and deal with any spread cells which might be in the system.
I didn't realise there were different kinds of breast cancer. I didn't realise, XXX is different from estrogen positive, is different from HER2 positive, and that there are actually, fairly different treatments depending on what you've got.
Áine, I wouldn't feel too bad about not knowing that because doctors didn't know it until comparatively recently. We had a tendency to think of breast cancer as a monolith and to adopt what our friend and colleague Dr. Slayman has, described as, a one-size-fits-all approach to breast cancer treatment, which clearly was incorrect. And I guess the first chink in that armor came in about 1958. I'll go back a stage further. It was known since the 1890s that some younger women with breast cancer, if you removed their ovaries, that their secondary breast cancer or the cancer in the breast itself could shrink. And people said, why should removing the ovaries cause a shrinkage of some breast cancers, but not all? And of course, the reason was that some breast cancers were sensitive to hormone stimulation, and specifically in the case of women, of course, to estrogen stimulation. And parenthetically, this observation was originally made by veterinarians who were treating different sheep diseases. And it became obvious in the first half of the 20th century that there were some breast cancers that would respond to various hormone treatments like removing the ovaries or giving estrogen itself, and some that just it had no effect on whatsoever. And it was a brilliant bit of research by a doctor called Elwood Jensen, in 1958, which showed that there was a thing called the estrogen receptor, which again was, we talked about receptors earlier, another little gate that sat on the surface of the cancer cell, which allowed estrogen to get in to feed the cell. Now, women will know that their breasts, their normal breasts, change at different times in their lives. A girl's breasts change at puberty, they change when she becomes a woman, they change during periods, pregnancy, they change at the menopause. And the reason they change is in response to fluctuating levels of female hormones, especially estrogen in their body. Some breast cancer cells have retained the normal estrogen control mechanisms. People sometimes think, oh my God, my cancer has estrogen receptor. That must be very bad. It must mean it's very dangerous because it'll be fed by estrogen. It doesn't. It means it's more normal. There's a little bit of the normality of a breast cell that it hasn't lost. That's why, in general, it's better to be estrogen receptor positive than not. It gives us other treatment options as well, such as anti-estrogen treatments. So that was the first hint we had that there was one group of breast cancers which were different. The second hint came with the work of Dr. Slayman, who discovered that a minority of breast cancers overexpressed the normal HER2 protein as a result of an amplification of the normal HER2 gene. And those cancers were worse. They were more aggressive. They much more frequently developed secondary cancer, and they did it much more quickly. The survival was shorter. And this was a very important observation. And indeed, for many years, we thought that the principal advance that HER2 represented was not as a treatment, but in terms of telling us who had better and worse cancer and whom maybe we would give more aggressive chemotherapy to. And in fact, it was his seminal advance afterwards that in fact there was a treatment which could be offered to those patients, which made it especially important. But that's only scratching the surface of the kinds of breast cancers. There were probably, who knows, dozens or hundreds of different individual kinds of breast cancers. There has been a big division more recently into 4 or 5 big types, which have treatment implications. One group that has been the subject of a lot of interest right now is called triple negative. And triple negative means that it doesn't have the estrogen or the estrogen receptor's cousin, the progesterone receptor, and it doesn't have the changed HER2. It is normal HER2. And this has a bad reputation, and many patients get very frightened when they hear the cancer is triple negative. And I always say to them, yeah, you know what, it isn't great to be triple negative, but still, if you've got a node negative, small triple negative breast cancer, you're still likely to be cured. If you have a triple negative breast cancer, it is still likely you will get a benefit from chemotherapy. Yes, there are some triple negatives, sadly, that we're not doing that well, but many triple negative breast cancers are cured. The outcome for patients with HER2 positive breast cancer over the last decade has been fundamentally transformed. Not every patient is cured, but let's go through it stage by stage. For patients with early stage disease who have either had surgery first or who have had chemotherapy and Herceptin first followed by surgery, for those patients, the outcome is improved by the addition of Herceptin like nothing we'd ever seen with a drug before. In some of the studies, the number of patients who had relapsed, which was already low because of the chemo, was cut in half, which meant that the percentage of patients with a cancer for which the prognosis without drug treatment was really bad, and now in an 80-90% prospect of never relapsing. I'll tell you something else, Áine. As well as doing studies in early stage breast cancer, we also do studies in patients that have secondary breast cancer. And we've observed it, and many of our colleagues have observed it around the world. Thankfully, it's harder to do the studies in patients with secondary breast cancer because there are that's HER2 positive, because there are far fewer of them. Because we're giving Herceptin to patients with early stage disease, we're seeing far fewer patients who get a treatment for early stage breast cancer and who then come back to us some years later with secondary breast cancer. In the HER2 positive space, that has become an uncommon observation. And all of the projections we made about trials we were doing for patients with HER2 positive secondary breast cancer, about how long it would take us to do the trials, what the numbers of patients we'd supply for studies, way off. It's great news because HER2 positive metastatic or secondary breast cancer has become, it always was, the less common type compared to the HER2 normal type, but it's become really uncommon now. Now, for patients that have early stage breast cancer, the impact of giving chemotherapy plus Herceptin in addition to an operation is simply huge. Probably, compared to not taking any drug treatment at all, we're probably seeing a reduction in the number of patients who will develop fatal secondary breast cancer by about 3/4. It is a huge, huge, huge decline. In fact, I believe it may be a little bit higher. For patients who had very bad locally advanced breast cancers, and in truth, we treated those patients with the intention of curing them, but the numbers were not good. Some would get cured, but sadly, many, many would not. It appears now that we're doing much better with those patients if they're HER2 positive and if they get Herceptin. So I think, yes, this is not the end of the story. And there's nothing nice about cancer, but the nice thing about research in this area is in the HER2 positive space, we have, in addition to Herceptin, which we've had for about 14, 15 years, and Lapatinib, which we've had for nearly a decade, we now have a new drug coming on board, which looks very good, called Pertuzumab. 2 other tablet drugs called Neratinib and Afatinib, which also look like they're very good, and an unbelievably interesting, exciting drug called TDM1, which is like the realization of a dream of cancer doctors for originally 100 years ago. A doctor called Paul Ehrlich once wrote a theoretical paper that cancer would have to be treated with what he called magic bullets, which were weapons that only targeted the cancer cell and which left the normal cells intact. And TDM1 is a drug like that. TDM1 uses a molecule of Herceptin literally tied onto a molecule of chemotherapy, so that the Herceptin goes only to the HER2 positive cells, it gets gobbled up into the cell, and the chemotherapy is only released inside the cancer cell. And the drug that was used, the chemotherapy drug that was in this, is too toxic to give people just freely into their veins. But when you only give it into a cancer cell, it has a hugely toxic effect on the cancer cell, but not on the normal cells in the person's body. So I think we're going to see much bigger advances in the HER2 positive space in the years to come. I think we're going to watch this space. One of the great fallacies of breast cancer is that you can only get breast cancer with a family history. And I would just like to point out to anyone who is watching today that if you or your doctor are worried about something, the fact that you don't have a family history doesn't mean you don't check it out. Most breast cancers are sporadic. They are not caused by a powerful genetic influence, although there may be some subtle genetic predispositions which are there. But there are a minority of breast cancers where it's very obvious there's something going on genetically. You hear, and the giveaway signs are young people getting the breast cancer, young people getting it sometimes in 2 breasts, family history of ovarian cancer, often sometimes in younger people as well. And when you hear of that kind of history, it really does ring an alarm bell with you that there may be genetic predisposition. Now, some people take a very fatalistic attitude and say, why should I know? There are real good reasons for knowing, really important reasons, not only for the sake of your family, but for your own health. A woman who actually carries one of the breast cancer susceptibility genes has a very high risk of getting breast cancer. And indeed, such a high risk that if she's had cancer in one breast, there's quite a high chance she'll get cancer in the other breast, and a reasonably high chance she could get ovarian cancer. And many women will, bravely make the tough decision to have preventative removal of their breasts and ovaries, to prevent them getting a whole new cancer starting. The first thing to remember and to emphasize is that most breast cancers are what we call sporadic. They occur in people that don't have a striking family history. They occur for whatever reason cancers occur in people. That's important because sometimes people have a false sense of reassurance, and indeed doctors sometimes have a false sense of reassurance that because someone has no family history, that they don't have to worry about that lump being cancer. If somebody has a feature which is suspicious for cancer, the absence of a family history does not mean that you should not get it checked. Okay? So what about those with the family history? A minority of breast cancers, a relatively small minority of breast cancers, are linked to clear-cut susceptibility genes which have been identified. And indeed, it's important to point out here that some of the research, collaborative research, which led to those genes being discovered had substantial inputs from Ireland, from Professor Peter Daly here in St. James's many years ago. And Irish patients were amongst those whose tissues were sampled to identify the genes. If a woman carries one of these genes, one of these alterations, there is a very high likelihood she will get breast cancer. The warning signs that a cancer may be genetic are younger age at onset, although it can occur in older life, bilaterality, which means that somebody gets cancer in both breasts. So if you hear of a young relative that's had breast cancer in both breasts, we'll say before the age of 50, that really, really rings a strong alarm bell that there's a high chance there's a genetic syndrome here. And the greater the number of first degree or close relatives you have that have had breast cancer, the higher the likelihood that it is genetic. So there are criteria which are used, and I will send letters to our National Genetics Testing Centre outlining the patient's family history and asking the doctors there to send a questionnaire, a detailed family history questionnaire, which goes directly to the patient. The patient then fills in the questionnaire and sends it back. And the genetics team then do an assessment based on the family history as to whether they think the likelihood is sufficiently high that they should offer that person testing. And if they do, there's a counselling step, because, the implication of having a diagnosis of the carriage of this gene is that you may wish to have both your breasts removed preventatively. You may wish to have your ovaries removed because there's also a higher risk of ovarian cancer. And of course, if a woman carries one of these genes, her sisters or her children, indeed her brothers, have a 50-50 risk that they too are carrying the gene. And not only could it make them sick, but they can pass it on to other family members. The other mistake people make is to assume that it can only be transmitted through maternal lines. And indeed, if your father had a sister who had breast cancer at a very young age, that is a little warning sign that there may be a gene lurking in your family if you've had breast cancer. So it's important to get the gene test done, and I find a lot of my time I'm reassuring patients that they should get it done, that there is not a good argument for not doing it. This is not something you want not to know. Sometimes people wonder, what about my beautiful 12-year-old daughter? Is it not a terrible burden for her? And I say, yes, she doesn't have to get it done yet. This is not something they need to worry about for many, many years. And what I always say is, God knows what preventative strategies we'll have in 10 or 15 years' time that she won't have to worry about it. But it's better that the family knows.